and more frequently, we can find indication of sparing concept of surgery with a partial nephrectomy or tumorectomy. In the guidelines, the place of the partial nephrectomy is very limited, theoretically it's very limited, and one of the limits of this sparing indication is the tumoral size. And in the guidelines, it's still considered that the best limit for partial nephrectomy is the tumor size of 4 cm. And theoretically, overpassing the size of 4 cm, this tumor must be treated by radical nephrectomy. It is a theory, it is the official guidelines, but as you know, limits are being pushed more and more, and actually it's possible to propose a partial nephrectomy to the limit of the T1 stage of the tumor, that means to the tumor size of 7 cm, depending of course of the characteristic and the place of the tumor in the kidney. So, because we are an academic school, we have to give the guidelines, but we have to give you the usual practice, and in the usual practice, limit of the partial nephrectomy will be pushed to 7 cm in some specific condition of tumor localization. And of course, we have imposed the indication of partial nephrectomy in a specific case, like congenital liver disease, for example, or of course in case of solitary kidney. The radical nephrectomy, it's a reform treatment of the bigger side of tumor, so starting from 6, 7 cm and going to the T2, T3 stage of the tumor. And many years ago, the only way of safe technique of radical nephrectomy was open surgery, and you had 2 kinds of access, the anterior one with the subcostal access, and the posterolateral one with the longer access. And when we started laparoscopic experience in neurology, of course, has been discussed possibilities of use of laparoscopic approach for treatment of this tumor. And in fact, this laparoscopic alternative is very logic for many reasons. The first point is to ensure that it's possible with the laparoscopic approach to respect the oncological rules which are imposed for treatment of kidney tumor. And as you know, these rules are coming from concepts given by Robson many years ago. The first concept is to be able to give first vascular control, because as you know that kidney tumor can be responsible of tumor spillage by the venous system, and if you mobilize the kidney with the tumor before control of the vascular pedicule, you increase the risk of hematologic diffusion of the tumor by the venous system. So we have had to prove that immediately it was possible to access to the artery, to control the artery, and to ligature the vein before any mobilization of the kidney and its tumor. Second point, very important, is to prove that it is possible with the laparoscopic dissection to avoid any direct contact with the tumor. That means that we have to find the good anatomical planes to be sure to be out of the limit of the tumor or the place of the section. And is it clearly possible thanks to the characteristic of the kidney, because we have outside of the fascia this fat atmosphere which allows a complete dissection of the kidney without any visual control and any risk of contact with the tumor. That means that laparoscopy approach will be reserved to the T3 stage tumor, because if you have a T4 stage, of course you have a risk of injury the tumor during your laparoscopic dissection, and perhaps you have a risk of spillage of the tumor. And the last point, very important too, is to be sure of the possible extraction of the specimen out of the abdominal wall without any contact between the tumor and the wall itself. Because in the first case, we have observed some metastasis of the tumor in contact with the muscle, just because surgeon has moved in traction the tumor and the kidney, and the contact with the tumor with the abdominal wall was sufficient to give metastasis. so we have now a very good quality of bags who are very resistant, and so we can pull on the bag. That means that we can press on the volume of the kidney to extract with a small incision without any risk of diffusion of the tumor in the abdominal wall. So we have had many cases, many teams, with the demonstration of this kind of laparoscopic radical nephrectomy and respect of all the rules, and so it was admitted that this surgery was safe about oncological aspect. It was difficult to propose this laparoscopic alternative because we had no evidence base, and so we had to wait 2003, and this very important paper coming from Kenneth Hogan in urological clinics of North America, and this guy said, as soon as this tumor is not a possible indication of partial nephrectomy, the standard will be radical nephrectomy with the laparoscopic approach. And at this time, 2003, it was possible to teach a technique of laparoscopic radical nephrectomy just because we had this kind of paper saying that reference was the laparoscopic approach. And year after, in 2004, it was the national meeting of American Association of Urology in San Francisco, and the final day of the meeting with the highlights about kidney tumor. The first highlights was to say the gold standard of the radical nephrectomy is the laparoscopic standard. So it was said, and the age of the laparoscopic radical nephrectomy was started. If we want to perform radical nephrectomy, we have two kinds of laparoscopic access. I said yesterday about pyeloplasty, but we said that we are going today to explain the differences between the two ways. And today we are going to talk about the two possible access. The first one is the extraperitoneal way, and this way was the one of the first used by the urologist trying to perform laparoscopic radical nephrectomy. And then we moved for certain team, we moved to the transperitoneal way like here. So your session program will be like described. We are going to move to Henri Mondor Hospital in Paris in a very famous team with a very large experience of this laparoscopic extra and transperitoneal experience of radical nephrectomy. And we are going to meet Dr. Osnek, who is one of the surgeons of this team, and is going to talk about the characteristics of the extraperitoneal way. And then we will follow a live surgery performed by Professor Alexandre Lattaille, who is the chief of department of the hospital in urology, and is going to perform for you a live surgery with extraperitoneal radical nephrectomy. And then we will talk with Eric Mandron, following the break, all the characteristics of the transperitoneal radical nephrectomy with pre-occurred live, and we will achieve the session with technique of partial nephrectomy, of course, because we have to talk. So this program is very busy. I'm going to give the micro to Andras Zusnek. I see him, he's ready for you. Andras.